Hello and welcome to the Imaging Wire Show. My name is Brian Casey. I'm managing editor of the Imaging Wire. Got a great episode for you today. Today, we're going to be talking about tools for identifying usual interstitial pneumonia, or UIP, a form of lung disease that's characterized by scarred lung tissue. And our guest is Dr. Jonathan Chung. He is a thoracic radiologist at the University of California, San Diego. Dr. Chung, thanks for being with us today. Can you tell us a little bit about yourself and about your research interests?
Yeah, Ryan, thanks for having me. I'm really excited to be here. So I'm a chest radiologist, cardiothoracic radiologist as well. So I do some cardiac imaging. But really the real reason why I went into chest imaging is because of my academic interest in interstitial lung disease. So I do pretty much all of my research, all of my clinical education in the setting of interstitial lung disease and pulmonary fibrosis.
Okay. And exactly what is interstitial lung disease and why is it important to recognize?
So interstitial lung disease comprises different subsets of disease, which are not that common, but also not that uncommon. It's sort of like that perfect amount of prevalence where you're going to see it in clinical practice quite often or often enough, but it's not often enough where you can feel comfortable with it. It's one of those kind of situations. And so, as opposed to things like pneumonia, aspiration, tumors, things are very macroscopic, and you could really point to it with one finger and say, oh, this is a pneumonia or this is a lung cancer. Interstitial lung disease is a diffuse lung disease. So you really got to look through the whole lung parenchyma to figure out what's going on. And so rather than involving things like the air spaces like pneumonia or aspiration, which are much more common, this involves sort of the other structures, which are oftentimes ignored when one evaluates a chest CT or a chest radiograph.
Mm. And what are some of the causes of these diseases? Is smoking a cause or some other factors?
So some of these diseases have causes. Like for example, there are smoking-related interstitial lung diseases, things like Langerhans cell histiocytosis, respiratory bronchiolitis, and other ones where smoking is a risk factor for development of them. For example, idiopathic pulmonary fibrosis. And so interstitial lung disease, there's such a broad spectrum of different things that are within that disease setting. It's hard to actually answer that question in a very compact way, but I just say it's a heterogeneous group.
Okay. Now, today we're actually going to be focusing on usual interstitial pneumonia, or also known as UIP. Can you talk a little bit about UIP and what might cause it?
Yeah, so I will, rather than saying usual interstitial pneumonia, I will probably just say UIP as well, just because it is a mouthful. But so in the spectrum of pulmonary fibrosis, that's probably the biggest chunk of interstitial lung diseases that people will see in clinical practice. UIP is the imaging and histological pattern that you will most often see, either as a majority or as a plurality in clinical practice. In a community, that rate is actually probably higher because those patients are essentially have not been picked over. Essentially, when you get to academic settings, we get quote unquote harder patients, like more difficult or complex patients, because the more straightforward patients should have been picked off in the community setting. So UIP, very common pattern that we see in the setting of pulmonary fibrosis. Secondarily, also very important because if you have a UIP pattern of pulmonary fibrosis, as compared to other patterns of pulmonary fibrosis, you don't do as well from an outcome standpoint.
Mm. Now, what imaging modality is typically used for identifying UIP?
You really need a chest CT. So people talk about using chest radiographs and distribution on chest radiographs to try to tease out different types of pulmonary fibrosis or interstitial lung disease. But we all know nowadays the chest radiograph is really a screening tool, except maybe in the setting of pneumonia or acute events. In the setting of something like an interstitial lung disease or chronic diffuse lung disease, you really want to look at CT. And so CT, specifically HRCT, is really what you want because that'll give you the maximum resolution to figure out what's going on with that patient.
Mm. So this is high resolution CT, so really high resolution. You can really see what's going on in that lung tissue.
Exactly.
Okay. So how serious is UIP? And I guess it's related to idiopathic pulmonary fibrosis. How related are these things and how serious are they?
Yeah, so UIP being an imaging and histological pattern can be due to different diagnoses. So it's not in and of itself a diagnosis, UIP. But most cases of UIP will be associated with idiopathic pulmonary fibrosis. And so, what percentage of UIP will be associated with idiopathic pulmonary fibrosis? It depends on your clinic, depends on your patient population. But in the US, most clinics, about 70% of UIP will be associated with idiopathic pulmonary fibrosis. Other things can also cause a UIP pattern, like connective tissue disease, sometimes hypersensitivity pneumonitis, drug-related pulmonary fibrosis. But from a simplistic standpoint, if you just take a step back, just have to remember, UIP usually going to be associated with idiopathic pulmonary fibrosis. The problem with idiopathic pulmonary fibrosis is that these patients don't do well. So it's not like something that you can just say, oh, they have this chronic lung condition like asthma or COPD, and we'll manage that. We'll see what happens. Idiopathic pulmonary fibrosis life expectancy not managed, so completely ignored, is going to be somewhere in around 3 to 5 years. And if you look at that, you compare that to all comers of non-small cell lung cancer, the life expectancy is very similar. So non-small cell lung cancer, life expectancy is 3 to 5 years. A unmanaged idiopathic pulmonary fibrosis patient, on average, they will also live 3 to 5 years. And so the life expectancy of IPF is essentially the same as non-small cell lung cancer. And so this has to be taken seriously.
Mm. No, one of the things that I've been reading about lately has been kind of an epidemic of silicosis among manufactured countertop workers. And Southern California and the LA region has got a pretty heavy, a lot of countertop manufacturing goes on there. Is pulmonary fibrosis something that's happening among these people?
Oh yeah, yeah. So we've seen a ton of it here in San Diego as well. So a lot of patients with end-stage pulmonary fibrosis from silicosis. So yeah, silicosis can certainly cause pulmonary fibrosis as well. Usually not a UIP pattern, but still end-stage lung that eventually will need transplant in many patients.
So it's important to identify that. So what are some telltale signs for how UIP appears on CT scans?
So classically, most cases of UIP are going to be peripheral and basilar predominant. And they have to obviously have findings of pulmonary fibrosis because it's a type of pulmonary fibrosis. So you're looking for things like reticulation, traction bronchiectasis and bronchiectasis, and areas of subpleural honeycombing.
Mm.
And so the last part of this is actually also very important. You don't want to have any other findings that suggest an alternative diagnosis to UIP. So if you have things that like really feel like another diagnosis or another pattern, that should stop you from calling this a UIP pattern. But I would say that probably at least 50, 60% of cases on imaging, you can make a confident diagnosis without having to approach pathology. And probably another 20% of the UIP cases, you can at least get a feeling for that this is going to be UIP.
Okay. What are some other challenges that radiologists face in identifying UIP?
So I think the fact that when you have any type of pulmonary fibrosis, so whether it's from a connective tissue disease, so rheumatoid arthritis, systemic sclerosis, whether it's due to occupational exposure like silicosis, like silica dust, or asbestosis, or even the setting of maybe people who are exposed to birds and they have a genetic susceptibility to develop fibrosis or lung disease from that bird exposure. As the fibrosis gets worse, they all start to look like UIP. Early on, they can look like their individual specific patterns that can allow the radiologist to make a confident diagnosis. But over time, as the fibrosis gets worse and worse and worse, it starts running into a UIP pattern. It's sort of like I use a car analogy, right? So I drive essentially a Toyota, right? I love my Toyota, but the Toyota is not a Mercedes, right? Everyone knows this, right? And when I see a Mercedes, I'm like, that's a nice Mercedes. So Mercedes Toyota comes off the line. Obvious which one's a Mercedes, which one's a Toyota. But after 20 years, driven hard, maybe the emblems fall off and everything like that. Maybe you get some body damage, rust. They get all like, ugly looking, and then you send them to the scrap yard and you scrap them with those compactor things, and now they're just big chunks of metal. That's kind of what end-stage pulmonary fibrosis is. So at that point, when it's sort of end-stage CAR, very difficult to differentiate one from the other. They just look like heaps of metal. Same thing with pulmonary fibrosis. As things get more and more severe, they start to just run into each other because the lungs can only react to adverse stimuli in a handful of ways. So that's really the most complexity of making a UIP diagnosis confidently.
Wow, that's a great analogy. Do you need a subspecialized thoracic radiologist to identify UIP?
Not necessarily, but you need that level of skill. So I know I have a ton of friends who are in private practice, general radiologists, who actually have a specific interest in interstitial lung disease for one reason or another. Don't ask me why, right? It's everyone, even if they do all of radiology, sometimes they'll gravitate to specific parts of radiology. And so they're probably just as good as me clinically at looking at these scans because they have put the time, the effort into learning it. But that's on them, right? That's because they're driven internally to learn more about these things. I would say on average, a expert chest radiologist is going to interpret these scans for HRCTs and looking for UIP better than a community radiologist. And why is that? Well, it's because a community radiologist, they're usually reading from head to toe, right? And they're reading multiple modalities. Chest radiologists, we just cover this part of the anatomy, right, of the chest, looking at radiographs and CTs and just MRIs for cardiac imaging. So if you're just covering this very, very focused portion of anatomy with just a handful of modalities, of course you're going to get better at those kind of things. And
Yeah.
so I don't want to just say that, you need a chest radiologist to do it. Certainly a very skilled general radiologist could do it, but on average, the chest radiologist will be better at it.
Yeah. Well, so fortunately, there's a lot of IT tools that are becoming available. We've got things like AI and that sort of thing to help radiologists. One of these is 4D Medical's Equip tool, which you've been involved with. Can you tell us a little bit about that and how it works?
Yeah, well, I had the pleasure of helping train it and validate it, and so I'm proud of it. Like obviously, it's I don't own it or anything like that. I wish I did, but I feel like it's like I'm like its uncle, right? It's like kind of like my not my baby, but maybe it's my nephew or my niece. But so this is to me a very important tool that can now be leveraged across the U.S. and across the world really. So the expertise in terms of HRCT interpretation, in terms of identifying UIP accurately, um, it's not where it needs to be. So I have a lot of friends who are pulmonologists who do a lot of ILD workup for patients. And so in the community setting, oftentimes they'll complain to me and say, the radiologists that they work with, they're not using the guidelines for UIP because you need to use a certain nomenclature to essentially get these patients the medications that they need, right? So insurance companies are pushing back. Also, it's hard to make a diagnosis of IPF unless somewhere someone says something about UIP, whether it's a radiologist or a pathologist. And nowadays, we really don't pursue pathology, surgical lung biopsy, as much as we used to, right? So really, a lot of it's relying on the imaging to try to make that diagnosis of UIP or not UIP, an alternative to a UIP diagnosis, right? And so
Yeah.
I would say that because we have this tool now, where we can almost democratize this expertise, right? For the past 15 years, I've been trying to educate people. I started my career out as a clinician educator, trying to teach people about pulmonary fibrosis, but it's hard. It's an uphill climb, right? It's like people only have so much bandwidth to learn what they can per unit time. And so I think we're still behind there. But the opportunity to use a tool like this, which could essentially be an expert chest radiologist interested in ILD, whispering into the ear of the radiologist, telling them, hey, this is what I think it is. Hopefully this can augment your diagnosis and your ultimate conclusion. I think that's a really powerful thing.
What sort of CT input does this software require? Like, are we talking about a full contrast scan or what?
Well, so I'm glad you asked that. It's can use pretty much any non-contrast chest CT that involves the whole thorax. And so contrast enhanced studies, it's not optimized to evaluate those scans, but anything without contrast and really any CT scan, it could be low dose chest CT for lung cancer screening, regular chest CT in the setting of HRCT, but any chest CT without contrast, as long as the slice thickness isn't greater than 3 millimeters.
So can you talk a little bit about how the tool is developed? And then I'm gonna grab a screenshot of the tool, and maybe you can kind of walk us through exactly what we're looking at. This is a sample report.
Okay. Yeah. And so the way this tool was created, so it's an AI algorithm, right? So it was compared against the gold standard of 5 expert chest radiologists. So obviously it was trained on tons of data labeled by radiologists, expert radiologists in interstitial lung disease. And then it was compared to 5 expert radiologists by consensus. So either 3 out of 5, 4 out of 5, or 5 out of 5 chest radiologists agreeing with a diagnosis, whether it's UIP or not UIP on CT. And so the exciting thing about this algorithm is that the accuracy is far better than other algorithms in the literature and even the previous version of EQUIP. We call this algorithm EQUIP. So it's EQUIP 2.0 essentially. And so now the accuracy is, in terms of sensitivity and specificity, is well above 90% with an AUC, area under the curve, ROC analysis of 97%. It's really, really good. The really exciting thing is if you actually compare it to any one of these chest radiologists. So remember, there was 5 radiologists. I was one of them. I was one of these, quote unquote, expert readers. So any one of these 5 radiologists, it performs quite similarly to 3 of the expert radiologists. But 2 of the radiologists, it actually performed a little bit better. It was actually exciting. Not statistically significant, but based on quantitative data, the number was higher in terms of its agreement with the rest of the group. And so that, to me, that's really exciting. So you're not giving anything up by using this EQUIP algorithm. It performs equally as well as an expert chest radiologist, right? And so people have pushed back on me. They said, well, it's not 100% accurate. But you know what? No radiologist, even expert radiologist,
Yeah, I
is
don't. Nobody
100%
is.
accurate. It just doesn't exist, right? It just doesn't
Yeah.
exist, right? And so because we know that it performs quite similarly to expert radiology or does a little bit better, I think we can be quite confident in its abilities to diagnose UIP on imaging. This report here, sample report, I think this is really a nice example of a positive case. So on the left-hand side, you would have that text essentially telling you in just words whether it thinks it's suspicious for UIP on CT or not. And on the right-hand side, it actually gives you a score, right? Anywhere from 1 to 10, its confidence of whether it thinks it's UIP or not. And I think this is important as well. So instead of just saying positive or negative, this will tell you its own internal confidence in there being UIP on CT. And so you could take
Interesting.
that data and you can essentially digest it and then make your own conclusion based on your opinion as well, right? So I think it's important because there's certainly going to be a difference between a QUIP score of 9 and 10, which is a high confidence score, or something like a 7 and 8, right? So if you personally thought that it was not UIP, and maybe you have some experience with interstitial lung disease, and it says that it's a 7 or 8, or maybe a 6 or 7, well, then you should take pause, right? So you shouldn't just assume that because it's higher than 5 that it's going to be UIP on CT. You still obviously have to be a radiologist yourself, do your job and do your due diligence. But that's different as opposed to if it was a 9 or 10 and maybe you thought that it was not a UIP on CT initially. Now you should really think about it, maybe look over the CT scan again and try to make the best diagnosis for that patient.
It seems to me like this score would and this tool would be really important, really helpful for like you mentioned earlier, community radiologists who have to kind of deal with a lot of different conditions that are coming in and maybe don't have the really deep experience that a thoracic radiologist like yourself might have.
I think so. So for an expert radiologist, chest radiologist who looks at a lot of ILD, looks at a lot of HRCT, I think it's a nice to have kind of tool. Like I certainly like using it, right? But just to make sure, just to confirm what I'm thinking, right? If it disagrees with me, sometimes, I obviously have to take pause, think about it, reevaluate the images. But again, I see more HRCT than most people, and so my confidence in what I'm thinking is very high. This is very different for a general radiologist who 1 second was looking at a knee MRI, next second was looking at CT of the head, and then an X-ray of like the spine, and now is presented with an HRCT with a complex CT pattern. This is great for them because it's essentially like having an expert chest radiologist, like I said before, whispering into their ear what they think it is. It's a UIP on CT or not UIP on CT. And so that can certainly help guide that general radiologist toward the correct diagnosis.
Yeah. And I think you may have mentioned it, but what is the equipped tools sensitivity and specificity again?
It's above 90%. I believe it was like just under 92% for sensitivity and specificity. And AUC again, like 97%. That's one of I think the highest I've seen for this type of algorithm.
Mm. And so workflow has become such a big issue in radiology and being more efficient. Can this tool help automate workflow in these thoracic CT studies?
So I think that what it will be helpful in terms of workflow is perhaps not making things that much more efficient. Like obviously there's going to be efficiency gains in terms of making the diagnosis faster, for sure. But I think in terms of screening all patients, so right now, um, there are tons of early pulmonary fibrosis patients, probably with UIP, with a lot of them with UIP, who are just falling through the cracks. Because if a CT comes in through the ED, where we're looking for aortic dissection, right? I'll tell you, even for myself, a person who loves interstitial lung disease, I'm not looking at the lungs as carefully as I do if an HRCT rolls in. I'm looking at that aorta extremely carefully, trying to answer that clinical question, and then get that study off the list as soon as possible so the patient be triaged. And so there are tons of situations like that where we order chest CT for other indications. Like, and then there might be pulmonary fibrosis on there that's completely ignored or just called reticulation or mild scarring, when in fact it's an early progressive pulmonary fibrosis. And
Mm.
so for me, the fact that we can have this tool that will essentially look at every non-contrast chest CT, including lung cancer screening CTs that come through a system and can flag them and then create a database that can then be mined to send these patients with significant pulmonary fibrosis down the right clinical pathway, that is a powerful thing. So
That,
this the idea of population screening.
yeah, that almost sounds like opportunistic screening or
Mhm.
comprehensive screening. Yeah. How important is an early diagnosis? What does that enable folks to do?
Yeah, so idiopathic pulmonary fibrosis or just pulmonary fibrosis in general is, I think, akin to the idea of maybe stroke or heart attacks, right? So when someone has a stroke or heart attack, you're trying to get them to the hospital as soon as possible. And so why is that? Is because time is brain and time is heart, right? Muscle in the heart, right? So the sooner you can revascularize things, the more brain will be preserved. The sooner you can revascularize things in the heart, the more myocardium will be preserved. So that's why we make this rush. It's the same thing with pulmonary fibrosis. Once it becomes fibrotic, there's no medication, no treatment which will reverse pulmonary fibrosis. And so what we want is we want to identify patients with pulmonary fibrosis as early as possible. We now have medications which can significantly slow the progression of pulmonary fibrosis. But you don't want to catch these patients once they have severe disease. Then what are you slowing? They already have end-stage pulmonary fibrosis. You want to catch them very, very early so they could be put on these anti-fibrotic type medications, and then their life expectancy can be increased markedly. And there is some data to show that these anti-fibrotics do indeed prolong life.
So it's really important to identify that condition early.
Yes.
Any other benefits you see from using the Equip software?
So there's a lot of research we're going to be doing with it. I think that overall, I think its biggest use cases are number one, helping radiologists interpret HRCTs at a high level, right? The level of an expert chest radiologist, number one. Number two, that idea of population or opportunistic screening. But the other one, and again, this is not something that is approved to do or anything like that, but there are these other cases. There are these cases, something called interstitial lung abnormality. So, what is interstitial lung abnormality? It's not interstitial lung disease. So, interstitial lung abnormality is just, it's an idea more than anything else, right? So, we invoke this term when we see a little bit of, and forgive my colloquial term, but it's the best way I could describe it, like schmutz. The little bit of schmutz, usually at the lung bases. So, a little bit of ground glass, a little bit of reticulation, and usually we would just blow those off. But now there's a ton of data that shows that these patients, they don't do as well. Their outcomes are worse. And a lot of these patients actually have very early pulmonary fibrosis. But for so long, we just blew them off. And so I would love to get all these cases of blown off interstitial lung abnormality cases, or even cases in which we identified interstitial lung abnormality, and use Equip to maybe stratify which patients are higher risk for progression and which ones maybe just have scarring. Because sometimes this schmutz is just scarring. It's just someone had a pneumonia, someone had aspiration, and that's not going to get any worse, but it's not going to go away either. It's just going to stay there at the lung base, this kind of reticular ground glass pattern. And so if Equip could help us tell us which one of these patients are actually early fibrosis, need to be treated with antifibrotics, and which ones actually just have stable scarring, that would be a big deal.
Yeah, well, it's going to be really exciting to see where things go with the Equip software and with your work as well. Well, Dr. Jonathan Chung of the University of California, San Diego, thanks so much for being with us and talking about UIP and the Equip software.
It was a pleasure. Thanks for having me.
You bet. All right, signing off for the Imaging Wire. My name is Brian Casey.